Hello, I'm Dr. Kim Kyung-won. Today, I'm going to talk about anatomy and physiology of maxillary sinus. This is the second class. And last time we talked about maxillary sinus, the basic concept, and the walls and septums. I'm going to talk about the anatomy and physiology of maxillary sinus, focusing on sinus membrane, vessels, and nerves. Today, I'm going to talk about primarily sinus membrane, blood supply, and nerves. Sinus membrane, as you know, it is called Schneiderian membrane, maxillary sinus membrane. In general, it is the thin mucous membrane lining the inside of sinus. Basically, it is a respiratory epithelium, immunologic defense function, and the mucosal thickness of the sinus is thicker in medial wall than in the lateral wall. The sinus mucous membrane is regenerated fast after surgery or damages. During the sinus surgery, if the membrane is injured, we can do the surgery again in 2 to 3 months. Let me show you a clinical case. The patient was referred to me by a private practitioner because a root tip went into the sinus cavity while the doctor was extracting the second molar. On panorama and CT, in the sinus floor, the root tip is observed. The private practitioner gave me a strong statement that I have to take care of it immediately, so I removed the root tip on the day. After the removal of a root tip, an oral antral fistulous opening was made. There's hardly any lateral wall. So if it is closed as it is, fistula may occur. Therefore, it is closed using a buccal fat pedicled flap like this. In this patient, about 3.5 months after the closure, it is opened again to do the bone graft and implant placement using a lateral approach. When the mucopedicle flap is raised, you can see the fat still remains in the area covered by the buccal fat pedicle flap. So in the fat area, a lateral window is created. As you can see, as the patient breathes, the sinus membrane moves as well. So when it was opened about 3.5 months after the closure, the torn sinus membrane is all healed, and you can see it is moving with the breathing. The sinus membrane is consisted of 3 layers. The pseudostratified ciliated columnar epithelium looks like stratified, but it is a layer of ciliated columnar epithelium. And below there, basement membrane, and below there, lamina propria. So basically, it is a respiratory epithelium from nasal mucosa. It comes in the sinus. Nasal mucosa is the thickest, and the medial wall is thinner, and the lateral wall we access often is the thinnest, as you can see in this picture. The physiological structure of the sinus membrane. At the top, there is a mucous layer, and the serous layer is below there. That's the double layer. The external mucous layer is a gel layer. It is rather thick and viscous, sticky. So it collects bacteria and other debris in the sinus, and it fixes the substances and transport them. And below it, there's an internal salt layer, a serous layer, to facilitate the flow, including the ciliary movements. So that is a serous layer. It functions as a lubricant. The salt layer and gel layer exist. The balance between those layers can contribute to the normal mucociliary clearance. The ciliary movement, cilia vibrates about 1,000 times per minute. Through the vibration, the mucus over it can flow. As you know, mucus movement, normally, it moves 6 to 9 millimeters per minute. The mucus, approximately 1 liter of mucus, which is much more than we think, is secreted per day. The secretions are, as I talked about it in the previous lecture, transported to the ostium through mucociliary clearance mechanism. This is the most important factor when it comes to the physiology of maxillary sinus. The mucociliary clearance. The mucus moves. Entrapped inhaled particles and bacteria are transported through the ciliary clearance. It is the immunological defense system of the sinus. Paranasal sinus, including the maxillary sinus, is usually kept in an aseptic condition. Route of movement, the bacteria in the sinus, as I explained before, goes through the maxillary ostium and to the middle nasal meatus and to the nose, to the nasal pharynx. The maxillary sinus is respiratory epithelium. Mucociliary clearance is an active transport system that heavily relies on oxygen. Where do they get the oxygen? The mucosa in the maxillary sinus, if I ask people what the color would be, some say white and some others, but usually I say it is whitish or pale blue. That means the maxillary sinus mucosa, the blood vessels there is minimal. For mucociliary clearance, oxygen plays an important role, but the oxygen from the blood vessels of the membrane in the sinus mucosa is very limited. Then, for maintaining the mucociliary clearance, where do we get the oxygen? The additional oxygen needs to be absorbed from the air in paranasal sinuses. That means for mucociliary clearance function, the physiological function should be maintained. What is most important for that? The patency of ostium that plays a pivotal role in maintaining the transportation system. So, in the maxillary sinus, if you look at the pathogenesis, the patency of ostium is the most important in the pathological process. If the patency is blocked, that causes the hypooxygenation, the lack of oxygen. If that occurs, as I said before, the hypooxygenation results in ciliary dysfunction and poor mucus quality. The ciliary dysfunction leads to retention of secretions. An inflammatory reaction may occur because of that. In an area like ostium, the mucosal hypertrophy and polyp in paranasal sinuses often occur in case of chronic paranasal sinusitis. Topical use of pseudoepinephrine can relieve effectively the nasal congestion. But if you use the topical pseudoepinephrine for a long time, it can cause the mucociliary dysfunction, and it can also cause permanent vasoconstriction, leading to rhinitis and anosmia. So the topical use should be for a short period of time. For maxillary sinus surgery, systemic pseudoepinephrine administration would be better than the topical use. The ostium in the maxillary sinus, a CT coronal view, there is a mucosa thickening a little bit on one side. And the maxillary sinus ostium is open and connected to the nasal cavity, and air flows pretty well to the middle meatus. In this case, you will not have problems during the sinus surgery. However, in this patient, there's a similar level of mucosal thickening. Due to the thickening and others, the maxillary sinus ostium is blocked. So in my case, before surgery, if I see something like this, I avoid the bone grafting during the sinus surgery. Bone graft or additional procedures should be avoided by placing rather short implants or just placing implants without a bone grafting to avoid complications. That would be the key point here. As I said before, the characteristics of sinus membrane, the thickness is about 1 millimeter or less, but there are large variants. Like usually it gets thinner in smokers, but sometimes it can get thicker too. The sinus membrane has little elastic fibers. That means when you raise a periosteum, there's a resistance that makes it hard. However, the fibers are not elastic. So, unlike the periosteum, you can raise the membrane easily. The details will be explained with the sinus membrane lifting. In terms of the color of the membrane, it is white. I would say it is transparent gray or white. That's the normal color. If it is thicker, it is closer to white. If the membrane looks yellow, there must be some inflammation, infection, so you can suspect pus inside. So usually it is white or transparent gray or blue. Next, the blood supply in the maxillary sinus. For the maxillary bone, basically, the blood supply comes from the maxillary artery, posterior superior alveolar artery, and infraorbital artery. And anastomosis is formed. For maxillary sinus blood supply artery, the most important artery is posterior superior alveolar artery, and infraorbital artery in the front, and greater palatine artery, sphenopalatine artery. Through various branches, the blood supply is made. During surgery, you would encounter posterior superior alveolar artery quite often. When we talk about the blood supply to maxillary sinus, infraorbital artery and posterior superior alveolar artery can be cited. Intraosseous anastomosis and extraosseous anastomosis need to be mentioned. Anastomosis means the two arteries meet together, infraorbital artery from the front and posterior superior alveolar artery at the back meet together. When bleeding occurs, when you control the proximal side, the distal side would not be a problem, but both sides can bleed when it comes to the anastomosis. I'll talk about it later. If you look at the path of anastomosis, there are many different patterns. The straight line is the most frequent one. If you look at the position, the usual average position in edentulous posterior segment, the position of intraosseous anastomosis is about 19 millimeters from that segment, and the extraosseous anastomosis is about 23 millimeters, or a little bit higher than the intraosseous one. Intraosseous anastomosis is in the lateral wall of maxillary sinus. It can be outside or inside. Usually it's inside of the thin lateral wall. If the tooth is lost just recently and the wall is thick, it is usually in the bone, like in the second picture. Or if the sinus lateral wall becomes thinner, like in this picture, it is between the sinus membrane and the bone. It can be exposed during the surgery, or it can be visible when the membrane is lifted. Intraosseous anastomosis, the presence and absence needs to be checked by taking CBCT imaging before operation. If it is thicker, like 2 millimeters or thicker, it can be easily detected and you know what to expect there. Intraosseous anastomosis, if it is present, when you create a lateral wall, it can cause bleeding. And when you lift up the sinus membrane, it can be an interference or it can cause bleeding. As intraosseous anastomosis is about 19 millimeters high, in that case, if there is not much alveolar bone resorption, the window can be created below the anastomosis. No problem in the surgery. But in the right, if there is a resorption in the alveolar bone resorption, the window forming may cause bleeding because the blood vessel goes through it. Let's look at two CTs of a real patient. On the left, you can see the intraosseous anastomosis above, and we have a space for lateral window. On the right, the alveolar bone is resorbed. Intraosseous anastomosis is detected here. When we create a window, bleeding can occur. If you look at the yellow arrow, when you create a lateral window in the front, you can avoid the vessel and do the surgery easy. But on the right, when you create a window, the bleeding inevitably may occur. I talked about the intraosseous anastomosis. You can see the bleeding occurs intraorbital artery. After stopping the bleeding in the front, you can see distal bleeding as well. This is anastomosis because in the front side, the infraorbital vessel is stopped from bleeding, but you can still see the distal bleeding. If bleeding is from the bone, you can clamp it, then hemostasis can be achieved using a needle holder. I don't use electrocutter. I just use the compression with a needle holder or hemostat. Posterior superior alveolar artery and infraorbital artery are stopped from bleeding with compression only. People ask me why it is called anastomosis instead of an artery. As you can see, two vessels in the front and at the back, they are connected. Anastomosis. As to the extraosseous anastomosis, as I said before, it is a little bit higher than the intraosseous anastomosis. Generally, when we raise a flap for sinus surgery, care should be taken not to cause damage to the extraosseous anastomosis. Care should be taken not to cause damage during a periosteal incision and flap elevation. You need to mind the location or position of it. Next, nerves, nerve innervation in the maxillary sinus, trigeminal nerve. The fifth trigeminal nerve out of 12 cerebral nerves. It has 3 major branches: ophthalmic, maxillary, and mandibular nerves. Maxillary nerve is dominant. Trigeminal nerve sensation, ophthalmic, maxillary, and mandibular nerves. There are 3 main branches. When we do maxillary sinus surgery, we need to consider the posterior superior alveolar nerve, especially in the upper posterior region. And in the upper first molar, near the mesial root and the second premolar, there is the middle superior alveolar nerve and the anterior superior alveolar nerve in the front side. In accessing the sinus, I usually block the maxillary nerve rather deep so that patients do not feel pain during surgery. In the palatal, there is a greater palatine nerve. This is the basic trigeminal nerve's maxillary branch. They are innervated like this. Let's summarize what has been discussed today. Through today's lecture, I focused on sinus membrane. It maintains the physiological status in the sinus. It is the most important thing when it comes to the physiology of sinus. To maintain the function, maxillary ostium patency should be maintained. Second, we are concerned about bleeding during surgery, so maxillary blood supply and nerves have been discussed. This concludes the 2 lectures on anatomy and physiology of maxillary sinus. During implant surgery, you will encounter more and more necessity to do sinus surgery, so basic anatomy and physiology of sinus needs to be understood so that you can avoid complications during sinus surgery. If you have any questions, please post that in the dental site. I will answer them. Thank you for your attention.